We good to go? All right, well, good afternoon, everybody, commission members and DMHA staff on the video, as well as anybody that's watching on YouTube. This is the fourth subgroup meeting of the Behavioral Health Commission, and this particular one is dealing with the issue of criminal justice interface. So really just to explore all the different ways which behavioral health, for better or for worse, interacts with the criminal justice system. We're going to have the subcommittee members introduce themselves. And actually, let me go ahead and pull up the agenda here so we can share it with everybody. Oh, looks like I need access to screen sharing.
Okay.
While Elaine is figuring that out, why don't we go ahead and go around and do introductions.
Jay, I'll bring up the agenda.
Perfect.
Wow. Okay.
Thank you, Elaine.
Sure. Yeah.
Appreciate it. If you could just give kind of your name and your title and affiliation, as well as just like a little description of your overall thoughts about this subgroup topic and why you were interested in this area. So I'll go ahead and start. My name is Jay Chaudhary. I'm the director of the Division of Mental Health and Addiction, as well as the chair of the Behavioral Health Commission. And I knew it before, but it's become even more stark going into this role, how closely intertwined the behavioral health world and the criminal justice world are. And I don't think those linkages are nearly as seamless as they could be. And I think that it's an area that's ripe for pretty radical changes in the way we approach the intersection of behavioral health and criminal justice. But on an optimistic note, I think a lot of folks around the state are aligned in that view, and so I'm really excited about the progress that we hopefully could make in this area. So before we get started with everybody else, I just wanted to thank a few people, Elaine Trepanier and Amy Brinkley, DMHA staffers that have been helping with this particular subgroup. They've been just fantastic on everything, as well as Ted Williams, who is our tech guru at FSSA, and he has been just instrumental with helping us figure out the process of live streaming 6 subgroup meetings, which has been not a small undertaking. So thank you to all of them. So I'll go ahead and call people just in the order they are on my screen. Ray, do you want to start?
Yes, I will, Jay. Good afternoon, everyone. My name is Ray Lay, and I am, among other things, the CEO of SMI Enterprises, LLC. And I am an Indiana Certified Recovery Specialist, Veteran Administration Peer Support Specialist, and Forensic Peer Support Specialist. I have lived experience with behavioral health. I live with a dual diagnosis, but with treatment, I am doing well on the other side, and I want to take as many people as I can with me.
All right, fantastic. Thank you, Ray. Dr. Negendang.
Yeah, hi, good afternoon, everyone. My name is Dr. Christine Negendang. I am the Chief Medical Officer at Adult and Child Health. I am a board certified forensic psychiatrist as well as addiction medicine specialist. I started my career at the Center for Forensic Psychiatry in Michigan, which is a maximum security state hospital setting for those found not guilty by reason of insanity or incompetent to stand trial. So was involved in completing a lot of those evaluations and the treatment of those patients. And throughout my career, I've worked in both the jail and the prison setting, created a jail diversion program up in Michigan, and was involved in the creation of multiple specialty courts for both individuals with severe and persistent mental illness, as well as substance dependence and homelessness. And so I'm just really excited about the committee and this subgroup. My interests lay in providing the people the best treatment so that there's no interaction with the criminal justice system. But if there is an interaction, how do we reduce recidivism and how do we decrease that population who are in our corrections settings. So I'm excited to be here. Thanks.
Katrina. Oh, is Katrina frozen?
Oh, there, is that better?
Yep, perfect.
Thank you. I'm Katherine Norris. I'm the Executive Director for the Indiana State Psychiatric Hospital Network. And that entails overseeing Indiana's 6 state psychiatric hospitals. And my interest in this group and this topic is kind of twofold. I have a master's degree in license and clinical social work in addition to a criminal justice degree. So I also have lived experience, and as most of you in this group know, that the bulk of my patient population within the state psychiatric hospitals currently do have forensic status. So it is impacting greatly our ability to get people what they need in the communities in a timely fashion. So I want to be a part of the solution and part of the change and the change agent that I feel like the state of Indiana needs to be the voice for those who are often voiceless. Thank you.
Thanks, Katrina. Steve McCaffrey.
Hi, everybody. Steve McCaffrey. I'm the president and CEO of Mental Health America of Indiana. And I guess just in terms of my interest, some time ago, like a decade ago, or I've kind of lost track, but Mental Health America used to try really hard to stay within the rails of mental health and the treatment world. And we kept getting pulled into criminal justice for all the obvious reasons, and finally realized that it was a mistake to try to stay within the lines of the healthcare system. And so we went full bore into the connection between mental health and criminal justice, and with pride and modesty, we were very much involved in the passage of House Enrolled Act 1006 several years ago that included the Recovery Works program, which we were influential in passing, and we've just continued working. And then in the bill this session, it expanded the JRAC Commission, the Justice Reinvestment Advisory Commission that Jay sits on, and so now Mental Health America representative and a Council of Community Mental Health Center representative will be joining that commission. So it all ties to this, and I'm excited to be on this committee.
Thanks, Steve. And then last, but certainly not least, Sheriff Nielsen.
Thank you guys very much for having me. I am honored to be on not only the committee, but this subcommittee. I've been the sheriff of Boone County since 2014, but I've been in law enforcement between the local agency, Zionsville, as well as the sheriff's office for 38 years. And I've seen over the years how the jails, especially the last 10 years, the jails have become the pseudo mental health facilities in the state of Indiana. And I vowed to do everything I can to try to help those people that end up in our facilities. But what I do want to say is that we are finally starting to see light at the end of that tunnel. And what I mean by that is working with the Sheriff's Association and Jay and the governor's office over the last 3 years, I really feel that we are making a lot of progress identifying the issues that these folks are facing inside our facilities, and how we can figure out a way together in order to make sure that that responsibility doesn't fall on the sheriffs across this great state. So I'm excited to be part of this subgroup and this committee and part of change that's coming.
Thank you, Sheriff. And I made the unforgivable mistake of skipping Rachel. In fairness to me, she keeps dancing around my screen. So, but Rachel, what do you want to go ahead?
Yeah, unforgivable. My name is Rachel Hallick. I am the Deputy Director and Chief for the Division of Mental Health and Addiction. And I actually, most of my career has been focused in the criminal justice realm. My first ever clinical experience was in a women's prison. And since then, I have had a lot of experience working in and designing programs for people reentering society from both the county, state, and federal level penitentiaries and jails, and I think while I love all of our populations, I think there's a special place in my heart for the criminal justice population. Several of you have probably heard me say a lot of times that when I was working in the criminal justice system, that I really got a glimpse of how we as a system, there are so many people in the criminal justice system that have had several opportunities for where we could have intervened and where the trajectory of their life didn't have to necessarily end up being in the criminal justice system, and the incredible rates of trauma and then the additional trauma that happens to the person that's incarcerated as well as their family and their children, and then the generational impacts of incarceration and the increased likelihood of children of incarcerated parents to also be incarcerated themselves. And I could get on my soapbox and stay up there for hours, so I won't. But I'm very thankful for this work group and for the people on it. And we have a lot of opportunity for really cool change here, and I'm excited to be a part of it. So thank you.
Thank you, Rachel. So just next for our next step, we're just going to review very quickly the reason we're all here, which is the statute that authorized the Indiana Behavioral Health Commission. And then as well as the subgroup charge or thing that we're tasked with as decided by the commission as a whole. And so, I'll see right there that this group will analyze the various systems that serve Hoosiers who are impacted by the criminal justice system. When the behavioral health system does not effectively prevent and treat people with mental illness and addiction, people end up in the criminal justice system. This group will examine those linkages and make recommendations, and then this group should coordinate with the Indiana Justice Reinvestment Advisory Council. And so several of us are on JRAC, and so that shouldn't be a problem here. This is the statute that authorized us, as you probably know. The interim report that we filed in October of 2020 said, haven't met yet because of COVID, but we certainly plan on exploring the idea of another interim report, possibly this fall, depending on how these subgroups go, with maybe some more immediate action items to present to the General Assembly and Executive Branch of the state government. So, and then here's the specific areas that we're tasked to take a look at. I won't go over them, but you can see it's all kind of wrapped up. There's so many different intersections of criminal justice, which is why the commission decided to make this a subgroup. And specifically here, I just wanted to highlight that there is a specific review of funding sources, and so we got to take a look at. And as you can see here, especially the first three, A, B, and C, there's a lot of room for exploration about how and if it's the most effective way to deal with a criminal justice system. So we look forward to those kind of in-depth discussions and conversations. And then number three as well, the cost of untreated mental illness. I think that you cannot take a look at how much mental illness is costing us, even from a purely fiscal perspective, if you don't include the costs on the criminal justice system. I'm sure everybody on this subgroup would agree. And so, I think we need to be mindful, and especially as we're kind of making our sales pitch to the people that make the decisions, that fixing this problem is not only like a moral imperative, but it makes good business and fiscal sense. So we're looking forward to that conversation as well. And these are the areas that the subgroup is kind of tasked with taking a look at. And again, this is straight from the statute. So, funding, again, we talked about that. Access to care. Again, there's a whole lot of, I think, intersections here with criminal justice, and as well as system design. This is, I think, what Rachel was hinting at as well. Like, why does it take so long to change to intervene in a way that changes somebody's trajectory? Why is a system designed to operate in silos? And then, many other assessment areas that you can see there. And as we have these conversations and flesh out, what exactly we're wanting to focus on, we can, fit these in to these assessment areas or create new ones. So, with that, I'm going to stop sharing this, go back to the agenda here. This is, let's see. was doing so well, and then I lost it. There we go. All right. So, for this first subgroup meeting, and kind of keeping with the way the other ones have gone, there's kind of two different tracks of discussion items that we would like to focus on. The first is to identify the kind of broad areas that we're going to take a look at and do a deeper dive into that will eventually turn into like final recommendations of this commission. Ultimately, the goal of this commission is to produce a report that will be submitted to the legislature and the executive branch and other interested stakeholders to make recommendations about how we can improve the behavioral health system and infrastructure in the state. And so, when we're talking about ideas, we should just keep that final end in mind, because ultimately, if we're not able to put it into the report, it's going to be difficult to force any action on it. But in addition to that final report, which is due, as you saw, in October of 2022, I'd like us to also identify, lower hanging fruit, kind of specific ideas to include in the commission, which we could possibly do in this interim report in October, or so we could figure out some other format to make it an official early recommendation of the commission, because I don't want to wait until 2022 if there's things that we can all agree on that make a ton of sense. So, with that in mind, the only last thing in the last meeting, behavioral subgroup meeting, somebody stumbled upon a phrase I think is a great way to start our discussion. And they were talking about how so often in their career, they would say, if only we had this, or if only we had that. And I think a really good place to start is with the if onlys, right? What are the if onlys that you've identified in your career? And I think that's a good place to start. So I'll kind of throw it open if that question makes sense. Like, what are some of the if onlys that you've identified or seen in your experience? And so who wants to kick it off?
Yeah, I can start kicking off. I mean, I could probably talk for 2 hours or so.
You could probably teach us a class on this. And so.
On my own if onlys.
Yeah.
But, some of the ones that I really would love to see is, the ability to fund treatment in jails and prisons. One of the things that we talk about a lot is that seamless transition out of the criminal justice system, so that people can remain on their medications and know their treatment team and have an appointment, right? And so, to have a way to have the community mental health centers be able to go into jails and prisons and get payment for doing that, so it's possible, and interact with their patients so that they can come out. That really would be very helpful in that seamless transition. Right now, the communication's not there, and and sometimes when people go into jail, for example, they're switched off their medications and then they decompensate. And of course, that causes a whole bunch of problems as well. So, I think the funding is always an enormous issue anytime you're talking about people in corrections, and how could that change, around that jail diversion. I think those are some of the really big ones for me. And the other one would be more crisis intervention centers, subacute centers, places that when officers are deciding what to do to help someone, that they have a place to go instead of jail. They can drop them off. They know they're going to get treatment and help, and they won't be back on the streets, right? So, I think some of those, looking at funding for the subacute centers would be great as well.
Fantastic. Let's if we can drill down on that first thing a little bit, because I think it's important to note that we're not everybody either watching or even on this subcommittee is an expert in how jail treatment is funded and implemented. So, maybe Sheriff Nielsen, could weigh how do you pay for mental health treatment in the jails right now? What's the current situation?
I'd love to follow up with that, and I appreciate your passion, Christine, because funding has been so crucial for us. When I became sheriff in 2014, here's the mental health services that we had in our facility for 225 inmates as our average daily population. We used our mental health center that's funded by the tax levy in our county. And for all 225 inmates, we had 2 hours a month of mental health services, not per person, but 2 hours a month total. Absolutely absurd. Today, we have over 100 hours a week of on-site mental health services in our facility. 100 hours a week. And out of that 100 hours, not only addiction, mental health are intertwined, but 40 hours a week of that is provided for institutional mental health. So when you talk about change in funding, we love the funding that's coming from the state when that can happen, but we didn't see it. And I pushed really hard. It took me 3 years to get my county council to understand that the mental health services inside our facility is not only going to reduce recidivism, but it's also going to change the lives of these folks that are suffering from mental health and addiction. So we were able to convince them, and now we're provided that funding mostly through our county council at this time. So we've got to get that cultural change from sheriffs across the state and across the country, really, that we've got to not only fight from a state legislative standpoint to get the funding, but we've got to stand up in front of our local cities and councils and make sure that we fight for funding there. So the funding is key. This is not cheap, but we're dealing with people's lives, and it's so important that we provide these services.
Yeah, thank you. And Steve, I know you've been looking into this issue from like a funding policy standpoint. So do you want to maybe elaborate a little bit on kind of what you've discovered and the direction that you think we need to go there?
Yeah, thanks, Jay. So when Recovery Works, I'll talk about it from a couple of different angles. When Recovery Works was first initiated, there was a conversation about whether or not it should be focused only on community-based services or whether or not it should be included in providing services in the jail. So just as a reminder, the state can decide if they want to provide behavioral health treatment and pay for it in jails. But the issue has always been that we rely so heavily on Medicaid for treatment, and you can't receive Medicaid if you're incarcerated. And so to me, there's a couple of possibilities. One, which, as you know, we all fought for Recovery Works funding that was originally cut, and it was restored. Now, not restored to the extent that we can provide services in all the jails in Indiana, but at least it wasn't cut. And secondly, and should be expanded in my view. And secondly, there's a lot of discussion around the country, and Jay and Rachel have been kind enough to join me in some conversations. In Ohio, they have I guess we could do this. I don't think there's anything that limits it, but what they don't suspend or terminate Medicaid when you're incarcerated. They just they change the name of the policy that you're on, basically, because if you're in jail, you can still get inpatient treatment if you need it outside of the jail. And so they essentially have the outpatient Medicaid program before you get into jail. Then they have the inpatient Medicaid program while you're in jail. Then when you leave, it just goes to the outpatient program. So there's no termination, there's no suspension, there's no re-upping. And so it seems like it is smoother than what many other states have and what we have. And then Kentucky has applied for an 1115 waiver, and they haven't heard, as far as I know, but they've actually applied. Now it's limited to substance abuse, which I would expand it to both substance abuse and mental health, but to try to get a waiver to have Medicaid reimbursement while incarcerated. And so to me, a potential solution is 1115 waiver, changing the policy, broadening the scope of Recovery Works. A combination of those three things, I think it'll get us a lot farther than where we are. And then I'll just throw in one more thing while I have the floor in case I don't ever get it back. I'm a big believer in treatment for misdemeanors, and that being part of the Recovery Works program, which I know you guys are piloting. And maybe with the Recovery Works money you have, there's an opportunity there. But to me, Christine kind of said said it, and let me just say it in a broader way. To me, our goal should be to ensure that everybody has the appropriate treatment that they need wherever they are in the spectrum, whether or not it's in the healthcare system or the criminal justice system, the whole way. And it's much easier to grab them early when it's a misdemeanor, and it costs less, and you have higher levels of success for treatment. If we can do more of that, that's a really good thing. And then if we can't, it's still important that we provide treatment for people in jail.
So we have so much ground to cover that, you know, the purpose of this meeting is sort of to do some bucketing, right? And I think that we've arrived at bucket number one. I mean, one in terms of chronology. I'm not making any value judgments here, but bucket number one, you know, is improving access to behavioral health treatment in jails. And we've already had a laundry list of ideas, you know, kind of mechanically that we could explore to do so. Does anybody have any additional thoughts on that particular bucket before we move on? Katrina?
This is semi in that bucket. I want to keep those individuals with IDD and traumatic brain injuries out of correctional facilities, and in fact, out of state psychiatric hospitals. So, and that experience has been, we've done more harm to these individuals, whether it's in a correctional setting or an institutional setting like the state psychiatric hospitals, but there is nowhere, it seems like, in our state to meet the needs of this particular patient population. And most of the time, the crime allegedly committed is very minute or misdemeanor, and they end up becoming more victimized. So fund that too, while we're funding.
Yeah, well, no, I think that's actually a great. Ray, did you want to chime in on the jail thing? Because I think Katrina.
Oh, most definitely. Unfortunately, and I'm not proud of it, Dr. Chris Negendang, as you stated about persons who have been found not guilty by reason of insanity. I'm one of those persons. I was found not guilty by reason of insanity or murder. And also, I still went to prison, was mandated for treatment, and straight up, I have to say that didn't help. That did not help. The major thing that has helped me was accepting my condition. I was able to accept my condition because I read my service medical records and my prison records also. The combination of them made it where it was hard for me to ignore. Okay, and plus what I was doing, I realized that was not doing any good. On the same accord, and as Ms. Norris just stated, I also spent 3 years in a mental institution. Okay, 7 years in prison, undiagnosed and untreated, and I was terrible. Okay, and I'm not trying to brag or nothing. I was terrible. If I'd have saw me coming, I'd have ran the other way. But anyway, I believe now, with me being a community health worker and Indiana certified recovery specialist, I have had that honor to work with other persons who kind of like are about in that same area. And one of the major things that I have constantly tried to work with them about was, how do you feel about your condition? Or do you have a condition? Okay, for the simple reason that by itself will be like a rocket fuel. Okay, it can be like a rocket fuel. It can be a motivator. And then hopefully we can get more of them who would like to kind of like get triaged, so to speak, so that they can be willing to see Dr. Negendang, or be a easier handful with Ms. Norris at one of the institutions. Okay, because I was not a happy camper at the institution, and I'm kind of sure that they wasn't happy with me either in prison or the mental institution. All right, but I look at me now, and I have to admit, it's acceptance, but it's also a continuous journey. Okay, but nothing wrong with getting the start to it by accepting.
So Ray, let me ask you a question then. So when you go into jails, how much does your lived experience help you connect with some of these folks?
It helps a lot. It helps a lot, a tremendous amount, for the simple reason that I can wear this. I have worn those shoes. One particular time, a colleague of mine on the board of directors with NAMI at that time, prior to him rolling off, we went to Newcastle, to the mental health unit. And I am a recovery specialist, proud of it. And they asked me to talk with the guys in there, but there's also a veteran unit there. I'm a veteran too. And I had that honor to speak with them. And the sergeant who was in charge of the unit, he came back and he said, Ray, I've been trying to get to talk to them guys for 6 years. You walk in here in 5 minutes, you got them listening.
Absolutely, yeah. I mean, and so just to put this into kind of something that we can turn into possibly some look at, I think just put a plug in for the folks taking notes. We made some inroads, I think, with peers in the jails and prisons, but it seems like we need to do a lot more there. So,
can I add one other quick thing, though, Jay?
Yeah, always, of course.
By the grace of God, here in Indiana, we finally have forensic peer support specialists. I am one, okay? And I am one with veteran. I'm a veteran peer support specialist. I have a substance abuse endorsement, and now, at the instance and encouragement of Amy, I'm also a trainer. I would love to get to go in that way, but I'm gonna also ask for a willing audience, a thirsty, and also, I guess I'm trying to get the right word, that audience that is primed. Thank you.
Thank you. We do have Dr. Nasset on, and it sounds like he's going to be kind of in and out, but do you want to maybe introduce yourself really quick and let us know who you are and your interest in this area?
Sure. Are you able to hear me? I'm talking on some earbuds, and I don't know if this works or not. Okay, good. Yeah, I'm Dr. Jim Nasset. I'm an emergency physician, an EMS physician, and also a SWAT physician and special officer with the Brownsburg Police Department. So have a passion for dealing with the situations that we're going to be talking about in this subcommittee. So glad to be a part of it.
Yeah, welcome. Well, we appreciate it. So, one of the, I think the best ways to conceptualize all the different things we're talking about, because again, this is a huge area, right? And so, is the sequential intercept model. So I think most of you are probably familiar with this model that kind of breaks down and deconstructs where and how people intersect with the criminal justice system. And so, we kind of jumped off very organically talking about the intercept point. I don't remember which one it is, but that jail intercept point, right? But I would like to take a step kind of back on I think it's back. I would be back on the intercept model to what's called kind of intercept zero. It's been touched on, Dr. Negendang. Kind of your second point was about the crisis intervention and stabilization. Dr. Nasset, as an ER physician, this is the point where you most often interact with people who are in the throes of behavioral health crisis that may end up entering the criminal justice system as a result of what they have going on. So, starting at that intercept zero community level, I guess I'll throw it open to the group. What are your observations? What are some things you think we need to focus on there? And I'll try to find the intercept model, a good PDF to kind of throw it up so we know what the hell I'm talking about.
Yeah, I mean, I think, with the initial intercept, right, is to provide the best possible care so that people aren't touching the criminal justice system at all. And I think around the idea of the kind of subacute or crisis intervention settings, part of that has to be the mobile crisis teams who are going out and helping officers in these behavioral health crises. And I think, funding for that has been challenging. We recently got a grant to do that, but, it's not permanent, and we don't know how long really we can fund it now. So, but it's such a critical part because, crises don't occur in my waiting room, from 8 to 5 kind of thing. So to be able to go out there and then to be able to provide, we've thought about providing telehealth services directly to, a psychiatrist or to myself. And, at 2 a.m, I can do that, right? If I have a phone, we can get, funded for that telehealth interaction. So, I think there's a lot of ways to do it, but, it usually comes down to funding, right? There's a passion to do it. We want it, obviously the correction system wants it, but how do we fund it? And staff it is the other issue, right? Is trying to figure out where can we find people who are interested in this. And I think across the state, staffing for the community mental health centers has been pretty tough. So that would all fit in the Intercept 0 part of it.
Yeah, of course. And so I wanted to just point out there that we do have a subgroup that is focused on the crisis, as well as a fantastic working group that's led by our state suicide prevention director, Dr. Poe, that's focused on these crisis issues. And so, I think we're going to leave that particular thing, I think, to that group that meets next week. I believe you're on it, Dr. Negendang. But this is all obviously related. I mean, we're all part of one big commission. So that's, I think, an important piece. I'd like to ask both Sheriff Nielsen and Dr. Nasset, if he's available, in your experience, to kind of weigh in here on like this beginning of Intercept 1. The 911 system, is probably what ends up bringing people both to the emergency room as well as the jail. And that's where, there's all kinds of intersections with both law enforcement going out as well as coming to the jail. And so I just wanted to get your take on some observations you've had there, and kind of what are some of your if-onlys with this particular part of the Intercept model.
Well, just real quick, I can tell you that we've got much better in the last several years. Ray just got back from CIT training. We try to train every one of our officers now in CIT. That is so critical. And I talked about changing culture before. That is a cultural change that we never knew in law enforcement, how to deal with these types of folks that are suffering from this disease. So the CIT is critically important to make sure that every officer out there is trained on how to deal with these folks. The other piece of it is our first line responders now are our communications officers, and they were by legislature now are considered first responders as of last year. And that is such a critical piece too. And they need to be CIT trained, because that's where that initial call comes from. And it's not always from somebody reporting that person that's in stress or in need. It's from that actual person. So I think just starting off, changing that culture on the law enforcement side with our officers that are responding or our communications officers that are answering the phone is absolutely critical.
Thank you. And if I may ask you a bit of a difficult question, I want to have these conversations because I think it's really important. There have been movements around the country focused on possibly other disciplines kind of being the ones to respond to some behavioral health crisis calls, as opposed to the law enforcement being the default. So again, I know you're just one person, you don't speak for the whole profession, but I just wanted to, give you an opportunity to weigh in on that as well, because it's a conversation we can't steer away.
Yeah, I'd love to respond to that. And I know Dr. Nasset, that's the first time I realized in your introduction that you're part of you're a police officer, which is awesome. Thank you for that, especially being a SWAT medic. That's important. I don't know where I stand with that yet. I know that if they are going to respond, they need to have an armed police officer with them. Okay. There is no doubt in my mind that we need more professionals to assist us when it comes to these types of things, but them responding first before law enforcement, again, Mike Nielsen, the sheriff of Boone County's opinion only, is absolutely ridiculous. We're gonna put people in harm's way, and we do not want to do that across this country. But having somebody respond with us once the scene is clear to assist us through that, I think is critical. But having them to respond initially by themselves is just wrong. It's just wrong in every way of law enforcement that I can think of.
Yeah, Sheriff, I completely concur with that. And I get to kind of be a part of this with our EMS folks also as a medical director for Hendricks County. And there are many, many mental, emotional dispatches. That's how it's dispatched out for our people. Many calls a day, honestly. And some of them are simply some cases of just some depression, certainly no violence threatened at all, no dangers at all. But there are others where you absolutely would need law enforcement present first. And you never know until you get there. And so we really rely on them to get in there, make sure the scene is safe. Two things: over 30 something years as a physician and 40 years in EMS that I have seen is exactly what Sheriff Nielsen said, is there's been such a transition over the years that law enforcement now is so much better. We all are, everybody I think is so much better at recognizing a behavioral health issue, a mental health issue, and involving and they're using de-escalation techniques and just doing the right thing instead of, busting in like sometimes we used to feel like we had to, and taking somebody down where simply some good conversation makes a big impact. Law enforcement is so much better at that these days. It's just wonderful. And I really praise my brothers and sisters in blue for what they have done, and brown, by the way, Sheriff. So, but anyway, yeah, I completely agree. Law enforcement needs to be there, I think, on all of these calls. But having these response teams, like was mentioned, would be fantastic. I know just a few places around the country. I've been to some meetings where folks have spoken and they've said, we have a team, I think it's Colorado Springs is one of them, where they have literally a van, a little minivan, driven by a police officer who has a social worker and a paramedic in there. So they are they call it community paramedicine or mobile integrated healthcare. And these folks respond to these calls. And of course, it takes money. They do a lot of their response based on grant money that they've received. But they go to these sorts of situations all over the city over and over again, and have made huge impacts. And so many people end up, instead of going to jail, they actually get some medical assessment, and sometimes end up in an ER, but very often can end up, at least in their situation, at a behavioral health hospital and get a full assessment and a workup, and sometimes admitted. And it's fantastic. That's in my book, in my mind, that's the ideal way to handle many of these things.
Yeah, thank you so much for that input. And I am pleased to announce that we are in the active process of bringing, thanks to the American Rescue Plan, something that I think could turn into that. I don't know that it will be that right away, because every single one of these mobile crisis teams requires so much, radical collaboration on the community level, right? You got to be a seamlessly working together unit. There's no reason we can't do it, but it's going to take some legwork, and that's, again, I would put that as a bucket as well for Elaine and Amy. Taking notes that this multidisciplinary mobile crisis response. And then the other key piece of that, to go back to the crisis, is somebody to respond, but the other piece of that is somewhere to take them, right? And so again, just to reemphasize the crisis stabilization center. Katherine, looks like we have another one of our members was able to join us after a lot of technical issues. Chief Lyday, would you mind introducing yourself and letting us know your interest in this area?
Yeah, thank you for having me. I'm the chief of police for the Avon School Police Department out on the west side. just west of Indianapolis. And we are in the business of connecting kids to a lot of behavioral health resources, a lot of things that we deal with from a criminal justice side are often best dealt with in behavioral health models and systems. And so we are really interested in building processes and systems rather than adjudicating them through the criminal justice system or through officers intervening, rather than partnering with some of our mental health supports that we have so readily available in schools. And so my hope is to be a part of developing those systems and processes for better outcomes for kids. So thank you for having me in this subcommittee.
Yeah, thank you and welcome. I think I'd like to leave Intercept 1 unless there's any final comments on it.
Yeah, I would just like to say one thing, Jay, if that's okay. I think as Sheriff Nielsen was pointing out, and you as well, it's really all about that collaboration and the respect for each other and so forth. And it's really a top-down approach, right? So the leaders in the community health centers and in the and in corrections, if they are on board, and I really appreciate Sheriff Nielsen, you being so on board with CIT and that collaboration with the mental health system, really takes that, right? So I've seen it both ways where we're fighting because we can't get leadership on board from either side, and other ways where everyone's on board and it works great, right? Because there's nothing that we can't figure out, and it just starting with that mutual respect, collaboration, and I feel very fortunate to have worked with just incredible people in my lifetime, but that's when it works best. So it's that culture change that's so critically important.
Well, let me ask the whole group this then, because I completely agree with you. I think everybody does. How can we broadly being, ultimately this is about making recommendations to the state, although again, hopefully there'll be a broader audience. How can we as the state encourage that culture of collaboration? Like what can we do? There was a bill that passed this last session, which I think will help, which created local JRAC, so local Justice Reinvestment Advisory Councils, which will bring all the relevant stakeholders together to start this collaboration. But what can we do as the state to help foment or facilitate that?
Jay, I think that's an important piece as far as the local JRACs, because the communities have to coordinate. And when you think about how rural Indiana is outside of the Indianapolis metropolitan area, those are old systems. They're far away from subacutes. They don't have mobile crisis interventions even available to them. So I think if I were to say, what can the state do? The state first has to educate these communities on the cost analysis, the stakeholder meetings, and who needs to be at the table, and then provide them with the data so they can make good decisions about the cost of whatever it is that we're focusing on that at that moment, whether it's keeping a person in a correctional facility or an institution. We all know on this call, I believe that anytime we invest in prevention or intervention, it saves in the long run, and the research supports that for decades. So we've got to get that message out, and it's hard to get that message to 92 counties with 92 cultures and jail formularies that are different in those 91 jails in Indiana. So I think we have a big task at hand.
Yeah, absolutely. And so, just to kind of put a pin in Intercept 1 here, I think we're talking about CIT. I think that is something, no brainer, but again, it has to be done in an appropriate to fidelity type of way, and there needs to be kind of broad consensus buy-in, improving local community collaboration, possibly with the local JRACs. Exploring the issue of like regional mobile crisis teams or units that are kind of multidisciplinary, that include law enforcement, EMS, behavioral health, other folks. Obviously, workforce is going to be an issue as it is always, but again, that's something we have to be mindful of and figure out ways to work around. And you know, we do have a subgroup dealing with the workforce as well. Ray, you got something else on this?
Yes. I'd just like to add again. I would like to interject that there's nothing wrong with collaboration. Learning from more of those who have also been doing something along the same, excuse me, area. Specifically, I'm talking about the Stepping Up Initiative. The Stepping Up Initiative, Indiana has 92 counties, only 3 counties involved, over 4,000 counties nationwide. And, but yet here in Indiana, Marion County just came in, just accepted and submitted the resolution, if I remember correctly, December of 18, and is now in Innovator County. So this is just something that we can, I mean, let's see what others are doing. Just like I have to add, specifically talking about Cahoots in Eugene, Oregon. Okay, and they are utilizing police, but prior to the police, there are persons going who are engaging long as it's non-violent. And the violence can, I mean, it can escalate quickly, and we all know that.
Yeah, there are quite a few models. I think that the nice thing is, you know, the nice and also maybe a little depressing thing is that other states are further out ahead of us on this, and you know that means that there are, I think, some good you know, toolkits and manuals and models and stuff that we can take a look at importing. We don't have to reinvent the wheel, which I think is ultimately a good thing on this piece. Okay, anything else on the Intercept 1 area?
The only thing I would add, and I think we've already said this, but in a simplistic way, it's, I think, to get the collaboration started is just getting people in the same room and talking, you know, and learning from each other and learning the challenges we each face and really coming to an understanding that we really all want the same thing, right? And then figuring how to get there. So I think it's that relationship building and really gaining a lot of understanding. You know, as I've worked on kind of both sides, what I see getting in the way a lot is just not realizing, right, the challenges everyone faces when they go out to a behavioral health crisis, right, from either side. And so just getting people in the room, talking about it openly and respectfully, you learn a lot and you really start to understand, you know, how best to work together.
Absolutely agree with you. So, you know, as we move along to kind of Intercept 2, which is when somebody's, you know, been arrested, they've been, you know, put in a, you know, Sheriff Nelson's jail and have been processed through the system. And, you know, I'm going to kind of blend, you know, 2 going into 3 here. You know, what this is the point, I think, where it's, you know, Katrina, it's your time to shine here, because this is where the issue, and again, we're not going to spend a ton of time on this because I think we could, again, the more time we spend on this, the more time we will spend on it, because it's a hugely complicated thing that we know a lot about. But this is where the issue of competency to stand trial is raised. And so for those of you that don't know what happens in Indiana when somebody's charged with a crime and they're found incompetent to stand trial, their criminal case freezes and they are committed to the Division of Mental Health and Addiction for competency restoration services. Now, historically, that's only happened in one way. They wait for a bed at the state hospital, they go to the state hospital, they're restored to the state hospital, or not restored to the state hospital, which is a whole different can of worms. And then, you know, once they're restored, they go back to jail, the criminal case restarts, and almost always they end up taking a plea and leaving jail right away. Because, you know, so they'll end up in the system for a year and a half for something that would have been resolved with a plea in 30 days if they had not been found incompetent in trial. There's a whole lot wrapped up in that. The current state of it is not good. There's a long waiting list for state hospitals. It keeps both Katrina and I up at night, I will say, pretty frankly, and we're working on different ways to fix it. But there are some pretty fundamental flaws in the way the system is structured and set up. And I think that, Katrina, I'll let you talk. Katrina and I are joking the other day, between the two of us, we just don't stop talking. So it's a problem.
And then It is. It's a huge problem. We know nearly 100,000 competency evaluations are done nationally, and half of those people are charged with misdemeanors. So if you want the what do I want or what do I wish, I want to change in the statute language. I want judges to work with their prosecutors and look at those specialty court options in Intercept 3 and getting people what they need, as opposed to jamming up the jails, the state psychiatric hospitals. And I want also there to be recognition of those individuals with organic brain issues that will never be restored to competency, and they just get lost in this system, in this revolving door. It's inhumane, and it's expensive. And the same thing is on the way out. You know, the discharge is as important as the admission in this process. So it is all of the things that we've talked about over months and months and months of we need to fix, but the statute also ties our hands in how we can fix things. So I think we got to get communities together. We got to educate people. We have to have the prosecutors on board with the judges. And that really happens at the local level, in my opinion, is if Sheriff Nielsen has a good relationship with his prosecuting attorney and judge, they're going to listen to him much better than someone else. And of course, I've had to follow this guy on stage too at events. So it's not fun to follow him on stage. But I do think it is the local level of really coming together and recognizing, and then when we make our recommendations to the legislature, that they've already heard from the people in their districts. Yeah, this is a problem and here are some solutions.
Yeah, I'll add two things that this is not an issue that just affects the state psychiatric hospitals and the criminal justice system. Like this, what this situation means is that you know, people that are found to be in need of a civil commitment, so they're examined by a psychiatrist and found by court to be either gravely disabled or a danger to themselves or others, often cannot find their way into the state hospital for a long time, because we have this whole boatload of forensics that we have to take care of, and that manifests in a lot of pretty ugly ways sometimes. And so this is something we have to fix. We will have, I think, a much more detailed proposal about this for the commission to take a look at some point. You know, Dr. Negendang, I know you're an expert in this area, and you've often talked about how, you know, there's certain ways that your former state did things differently that might be worth importing here. So I don't know if you want to chime in there.
Yeah, I mean, I think, specifically, yes, right, to all the problems that we have here with the risk of keeping people in jail and in waiting for that state hospital bed. And we've talked before about not everyone needs state hospital beds to be restored to competency, right? So looking at those outpatient competency restoration or jail-based, so that we can get people treatment quick before they, I said, a lot don't even need to be in that really high level care. So that's part of it. And I think as far as from a legislation standpoint, each state is really different. And it's interesting to look at the ones that seem to be doing a good job or, kind of picking at those things. One thing that, I liked with the Michigan system is that for those patients who were found permanently incompetent to stand trial, right, those people with traumatic brain injuries, for example, or developmental disabilities, they didn't take up the system, right? As soon as they were deemed permanently incompetent, they could be, released and into outpatient care, and they wouldn't have to try to go back and go through the court system and so forth. So it really is different in that way. And there's also timeframes. There's other timeframes that you had to be restored within 1/3 of your maximum sentence. And if you were there 15 months on even very serious charges, that was sort of that maximum. So there are some timeframes put into that as well. The other thing is with each state is there's really a very different approach to commitment orders and, how people can receive medications and so forth. And Indiana really makes it challenging, right, to get people the care they need. Sometimes we know that with a lot of mental illness, particularly, people who are suffering from psychosis, part of that is they don't have insight, right, into their condition. And so it's challenging to help people with that or have people see that they need treatment. So I think in Indiana, it's pretty challenging too, just to get people on medications that they need. So yeah, there's a whole bunch there, but I think there's also a lot of people doing a lot of different things. And, it's kind of nice to look at other states, see what they're doing, not necessarily reinvent the wheel, but, just picking and choosing what makes sense, kind of as a wish list of what we might be able to do.
Absolutely. And so again, we could spend hours on the issue of competency. What I'd like to do is put a plug in this, and the DMHA team will have a very thorough, detailed proposal for the commission to evaluate and hopefully end up supporting, in eventually. And so, because it is, again, it's simultaneously a very distinct area, but it's also an area that has huge ramifications in Sheriff Nielsen's jail, in the emergency room, in all kinds of other places. So it's one that we just have to figure out, and we're going to keep working on it until we do. Okay. Well, what do you all think? Do you think it makes sense to go down this intercept, or is there something else that somebody else wants to take this piece? I'd like to ask Chief Lyday. We haven't really talked at all about the juvenile. Is he on?
Yeah, I'm on.
Okay.
I sure am.
We haven't talked at all about kiddos and schools and the juvenile system at all. But I think this is as important, if not more important, to talk about as it relates to the intersection between juvenile justice and mental health. So I'd like to actually maybe give you the floor for a second to chat about that, because it's one thing I don't know much about personally, and I think that we have to go look at.
Yeah, so the difficult aspect for juvenile justice right now is the push for many, for juveniles when they commit any kind of juvenile delinquent act, to get them resources, but the disconnect between getting them the behavioral health screening, intake, and services is availability of those resources when that student doesn't qualify for Medicaid. Many of the school-based resources only take Medicaid kids or kids who qualify for Medicaid, and the availability of services is extremely scarce for them. And so a lot of times the only way to get affordable behavioral health therapy or any type of resources pertaining to the mental health is through the court, which means a referral to the criminal court has to be made. And in fact, for there to be mandatory services, the only way for us to do that currently in a lot of places is to refer them to criminal court, which means we have to do a police report. We have to refer them to the prosecutor's office. Probation has to be involved. When our schools, many of our districts have the capacity to get them some of that help on the front end. And so a lot of our officers only have the choice to either arrest so they can get the resources they need, or do nothing because they feel like the arrest would be too detrimental for them. And so there's not a model for a lot of places to get them those resources pre-arrest, which would significantly drive down juvenile delinquency, which I think is all of our goal. And so again, finding a model and finding a system where we could bring those mandatory or those necessary resources to a kid before the point of an arrest is made would be tremendously beneficial to juvenile justice in Indiana. We just don't have much of a model for it.
That's such a great point, because I've heard so many times from prosecutors or police officers or even judges that, we put this kid into the system so they could get resources, right? And that the system meaning the DCS system, the
right.
system meaning the juvenile justice system, and that is so backwards, right?
Yeah, because we could bring those resources to them before a referral to the criminal court, whatever needed to take place. Those same resources and the same level of accountability could happen pre-arrest. It just means now you don't have to check a box to say you're arrested or deal with the prosecutor in punitive way. It's more of a support for them, and they would still get the same consequence, the same resources, the same restorative action that they would get post adjudication.
Well, there was quite a controversy, and I don't know if all of you have been around long enough to remember, but where a state legislator couldn't get adequate resources, and the juvenile court judge at the time actually did put him into the legislator's child into the system so he could get resources. So it's so bad that we're not talking about kids that are borderline Medicaid. We're talking about people that have resources and the ability to work the system still couldn't figure it out.
Mm-hmm. Yeah, it's true.
Yeah, so I think this is frankly an issue that's worth a deeper dive, maybe between this group and the children and families group. So, Elaine, Amy, if you want to put in the notes that, I don't know how to characterize it, but just the whole concept of needing to put, especially a kid in the system to get them help, is something that I think we have to explore and tackle as part of this commission, because it is, it's one of those things that unless you're in the system, you don't believe it, because it does not make a lick of sense. So yeah, thank you, Chief Lyday, for bringing that up. Is there anything else on the kids side that you think is worth chatting about?
I would. The only other thing for us is, again, and I said this yesterday in the other subcommittee, is that I feel like modeling is extremely important for us. It's good to have education for these different intercepts. I think clear modeling is really important, and scalable models, depending on the size of your county resources available. I would just love to see all of this come together in a usable, actionable model that we could easily navigate, scale to size, and promote articulately with that scalable model.
Yeah, absolutely. Thank you. I am muted. So we have a ad hoc subcommittee member here. There's Harper. She wants to say hi. Here I'll just before we get to some of our business items, I'd like to just throw it open to the whole group to just what else is burning, what else is pressing. Are there extremely low-hanging fruit that you think that we should attack? I mean, this is not the last meeting of this subcommittee. We can certainly bring it up and refine later, but just throwing it open right now.
Well, Jay, this is the opposite of low hanging, but I wanted to raise it. I don't know if we want to consider it or not, but one of the issues that keeps coming up in the legislature is, and has for the last several years, is whether or not it makes sense to have regional treatment centers for people that would otherwise be incarcerated. And I don't know, it seems to me like if we think that's a good idea, it'd be helpful to say that. If we think it's a bad idea, it's helpful to say that.
So yeah, I mean it is the opposite of low hanging. That's on the top of the tippy top of the canopy there. But it's also super important. I mean, I guess unpack that, Steve, because I think there is a spectrum of things that could go into that. Like, are we talking ordered to from court? Are we talking in lieu of going to the justice system? Like, I think, what do you think about that?
I mean, I think the way it's been framed up until now is that a lot of the sheriffs in the state have been concerned about overcrowding in the jail, and that they are not, mental health providers, and they're put in that situation. And so some have expressed interest in an alternative placement, essentially. And so the concept that has been discussed, but it's difficult because it's unclear as to who would own it and how to be paid for and those kinds of things. But the question is, if there was a regional treatment center that had some level of security, that if sheriffs wanted to presumably take people with behavioral health conditions that they can't serve in their jail to the regional treatment center that would presumably provide them with better treatment, then the individual gets better treatment. The sheriffs aren't put in an awkward position. yada, 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 trying to make the system work a little bit better. But it keeps getting, it doesn't get much farther than that, because there's a question of, well, would the sheriffs own it, control it, pay for it? Would the state own it, pay for it? But kind of like, and I'm not saying I'm not saying this is the exact analogy, but like Isaac Ray, it's a behavioral health facility that has security, that DMHA runs. Back in the day, when they first built Newcastle, it was supposed to be a special needs facility with a primary focus on behavioral health. And so there have just been these ongoing discussions about how do you provide appropriate treatment for people that are a security risk, you know, that you can't put in the community, you probably can't put in a state hospital. There needs to be security, but they really do need treatment.
So, I mean, Dr. Negendang, is there an analogous type of setting that you're familiar with there that Steve's talking about?
Yes and no. I was thinking about that. You know, the Center for Forensic Psychiatry up in Michigan it's not for people who are, well, that's necessary too. There are sometimes people who do come from the jail and prisons who cannot be treated at all. It's mostly for people who've been found not guilty by reason of insanity or incompetent to stand trial. However, the setup as far as having security and, you know, it's considered a maximum security psychiatric hospital. So, you know, it's 24/7 treatment, you know, so there's, but there's also there's a security measures, right? There's security on every unit and, you know, you can't get in or out easily, you know, that kind of thing. So it's very high level security that way. So in that way, it's similar. So, you know, I think if we were trying to figure out how to create something like this, that would be a good model as far as how do they handle that, right? The security risk, the safety, and so forth. But it's a really amazing facility because it has so much it's treatment oriented. You know, there's a main street, which is all inside, but, you know, that has different shops so people can learn how to kind of reintegrate in society and so forth. So it's really a neat, it's a very neat location.
Yeah, I mean, there's so much to unpack there in terms of both viewpoints, I think, because I think that there's going to be a strong and vocal contingent saying you're just creating more institutional settings. And again, I'm not saying that I'm opposed to that. I'm just saying that's going to be, I think, one of the things you're going to have to avoid. I don't see why we can't talk about it more as both a subgroup and a commission. I think I'd like to figure out if we could, you know, find like 3 models or something that we could take a look at of what this would look like, because, you know, do I support essentially the building of mini state hospitals around the state? You know, probably not, because we can barely staff and run the hospitals we have. Do I support you know, more alternatives to either jail or DOC or state hospital? Absolutely. And so you know, the devil will be in the details. But again, thanks for raising that point, Steve. I think it's something that we should certainly talk about, and especially to the extent that we can hone in on some specifics about what that would look like.
If I could just interject something
Yes,
there,
please.
Steve, thanks for bringing that up, because that has been talked about for a very long time, but the concept of regional jails have been talked about too. So does it make sense for me to have a jail in my county, or do we have it in another county and it takes care of the surrounding counties? First and foremost, you'll never get 2 to 3 to 4 sheriffs to agree on how to run a jail. So that probably regional jails, even though it comes up all the time, always just goes by the wayside. And as far as the treatment centers, we as law enforcement, as sheriff's offices, have to stay in our lane. We shouldn't be in charge of a regional treatment center for sure. That's got to be something that either the state does. And we've had some really good conversations with Jay and his team and visited Logansport on how we can use the current facilities and expand those maybe in order to try to help us facilitate some of our needs. The other thing that I'll say is we're getting ready to build another facility. And it is not a facility that is going to be based off of incarceration. It's going to be based off of rehabilitation. And if we build another 500 bed facility in my area, I'm going to fill it up overnight, and it does nobody any good. But if we focus on a mental health ward, a medical ward, rehabilitation ward, all those types of things when we build this, and this is the concept that we're trying to build. We actually have a meeting on Monday to fund it. But just focused on rehabilitation and not incarceration. And then I think we can work with the state on how do we help provide those people that have this mental illness to try to get people in there to staff it and do what we need to do. So it gets back to collaboration against everybody, with everybody, in order to try to make it work.
Yeah, thank you for that input, Sheriff Nelson, and good luck with that meeting on Monday. So I think in this context, what we can agree on is that there is a significant gap in a certain type of setting. It's unclear exactly what that setting is, but I think people call them step downs, people call them kind of subacute. You can call them kind of like regional treatment, whatever you want to call it. There is a need for more than community, full on community outpatient, but less than full blown state psychiatric hospital or incarceration, right? And that may be something to explore further in further meetings of this subgroup. Does that make sense? Is that kind of what you're getting at, Steve? I mean, because I think it's when you say regional treatment center, I think that raises a whole lot of questions. Not that may be the right move, but yeah, I think that.
Yeah, I don't know that I have an agenda, except that I've been in a lot of meetings on it and I get asked about it all the time. And it's usually from law enforcement people and not mental health people. I'm just saying, if we're going down a path or we want to influence that path, I'd like to see a lot of mental health expertise be part of that discussion.
Well, and I'll say, just kind of jumping in on this, there, in my experience and in the programs I've developed and supervised over the years, I would love to see development of, and I think using peers might be a way to really connect with this. But the attrition and the disruption in quote compliance almost always occurs within transitions between agencies and levels of care, and almost always it is due to, at least in part, the client having to go through the entire intake process and getting to know a therapist again and restart their healing journey, and it just feels needlessly re-traumatizing. And also navigating our system, it continues to be complex, and it would be wonderful to start seeing and developing some partnerships very intentionally, perhaps driven by peers, where when a person's incarcerated, they start getting this intensive case management. They have some emergency funds available to help support their family members, because often people who are incarcerated have children, and often it's one of the grandparents that is keeping the kids, and they're usually very, very financially strapped. And really working and staying with that person as they exit incarceration and go through their different levels of care, and making sure that there is a solid, constant, consistent person that is there, that can be kind of a foundation as they're navigating the system that they have in front of them. And I think if we were skillful about developing that sort of a resource, I think it would even decrease the need for, and there still would be a need, but I think it could potentially decrease the need for these sorts of facilities, because we would have the supports in place in the community to help keep people stable and supported.
Yeah, that's a fantastic point, and thank you, Rachel, for kind of bringing it back to the people who are in these. I think we've been talking about systems, right? And that's important, and we need to talk about systems. But I think we also need to remember that these are people, and so I think we should definitely put a pin in the notion of a sort of a peer-led navigation system. I think it would that would be again, I think that the devil would be in the details, but we could, you know, talk about designing a system where you didn't feel like you were going through this alone. And I know that sounds like kind of soft, but I think it's so important. I mean, you know, I'll share, I recently broke my ankle on vacation and had to go through emergency surgery in Tennessee. And because of my kids were there, my wife had to be with them. I was pretty much going through this whole thing by myself. And I'm somebody that, you know, is, you know, fairly sophisticated in terms of how these things work. And it was, you know, and have all kinds of privileges and everything. And even then, I think it was pretty daunting to just like answer these questions and do all that sorts of thing when like literally like you're on pain meds, you're just kind of like traumatized by what just happened. And, you know, and you multiply that by 100 or 1,000, you're talking about the experience of somebody that's trying to navigate the system themselves. And so, you know, I'm really intrigued by that notion and something we should explore further.
Yeah, I'll just add to that too. And I know I've shared this with some of you, but you know, in other states, there's models where the community mental health centers are tasked with with providing treatment in the jail system, and that is very beneficial in this seamless transition, because that same case manager and sometimes the same psychiatrist who are working with that person in the jail will also be working with them when they're released. And so then they keep track of exactly what you were saying, Rachel. You know, when are you being released? Do you need a ride? What do you need to, you know, make that transition as easy as possible? Here's your appointment at our outside clinic, you know. And so it's really, it was really helpful to that seamless transition, and it just really decreased stress, right, on people. We were able to get them their medications before they left the jail, so they didn't have to worry about that. And it really was, I mean, you know, ethically, it was 100% the right thing to do. And of course, it did really slow down recidivism and, you know, reoffending. And so I just love those models that have that seamless transition.
So as you can tell, we barely scratched the surface. Almost hour and a half together. We have 8 minutes left. So, you know, with some of the other groups, it was sort of unclear if we wanted to meet again. I think we definitely need to meet again before we talk, figure out through with the whole commission. I'm assuming everybody agrees with me. I hope. Any dissents to that? Okay. So just kind of mechanically speaking, we've treated each group individually in terms of this question. And so, you know, but I think for this group, it would be a good idea to select a chairperson just to, you know, number one, I think help with developing ongoing agendas and refine and focus the conversation to get to the point where we, you know, would need to, you know, get to the point where we need to get to in order to present something usable to the commission as a whole, right? As well as sort of report out at that behavioral health commission meeting. So the way we've been doing this to avoid the kind of awkward silence that usually results when you ask for this type of thing over a meeting is, if you want to opt out of chair responsibilities, if you could email, who the email, Rachel?
It would be Elaine, Amy, and yourself.
Yes, yeah. If you'd email Elaine, Amy, and me that you don't want any part of being the chair. If it ends up everybody opts out, then, you know, we can deal with that. Cross that bridge when we get there. But, you know, the responsibilities would be essentially to help spearhead this group and help myself and Rachel and the DMHA staff come up with future speakers and topics. If, you know, do we want to hear from, you know, somebody on the kids issue? Do we want to have a joint meeting with another subgroup, that sort of thing? So, you know, let us know if we want to do that. Elaine or Amy, do we want to try to schedule the next meeting date now, or do we want to do it by sort of a poll? What do you think?
I'm all about doing it now while we're together. I think it's the most efficient way if everybody's game for it.
Yeah, absolutely. You want to just throw out a couple dates?
Sure. So we are looking at about a month out. Bear with me. So we would be looking at the week of the 24th. Is there any date that does not work for someone that week? May
I'm
24th.
actually
my
on
apologies.
vacation that whole week, but don't
Okay.
pause on my account.
We could meet sooner, especially given the amount of conversation and content. Jay, are you open to that?
I'm good with that. You know, I'm also okay. And so we are going to stay virtual for the time being. So if that makes things easier for folks, that's fine. Or the week after, the first week of June would be fine too.
Okay. So first week of June happens to be that 4-day week with Memorial Day on Monday. Is there any conflicts for anyone then?
I'm personally out every day except Tuesday, leaving town and working combination. So from my standpoint, but don't hang it up just for that.
Go ahead, Jay. Sorry.
The afternoon of the 4th. Would that work?
Sure. Everyone else, afternoon of the 4th. And does this time work? 1:30 to 3? Okay. June 4th, 1:30 to 3 it is.
All right, fantastic.
Thank you.
And then remember to opt out of chair duties if you don't want them. And you know, and if you have more questions about it, we're happy to chat as always. And if you think of ideas or speakers or topics or resources, like let's keep a robust conversation going. You know, really look forward to getting together again. Thank you all so much for being open and honest and frank about your experiences and ideas. I think we can really do a lot of good. I think that the groundwork's in place. I think you know, we've been having these conversations, like Steve said, for some time now as a state, and I think we're ready to take that to the next level. So I look forward to working with you all to lead us there. Thank you.
Thank you.
Have a great weekend.
Y'all take care. Thanks.